Welcome back and good afternoon, everybody. This is our final session for day one. I hope you enjoyed the earlier sessions today. And this session is titled Addressing Health-Related Social Needs to Improve Rural Health, Ideas for Action, Key Elements of a Rural Community-Based Demonstration to Advance Whole Person Care. My name is Becca Bolus, and I'll be moderating today's session. And just a couple of reminders before I introduce our speakers. The first is that we are offering conference captioning services. Within each section, you'll automatically be provided with that service. If you don't need it, you can just click the pause stop button and it will stop. And the second is to please be sure to complete the session evaluation using the feedback button. Our evaluation is just 4 short questions, and your feedback is very helpful to us. And it is required if you're seeking continuing education credits. So with that, I am now excited to introduce our speakers for this session, Deb Deatrick and Andy Coburn. And with that, Deb, I will turn it over to you.
Great, thank you so much, Becca, and good afternoon, everyone. We want to welcome you to this session. And Becca has already given you our relatively long title, so I won't reread that. My name is Deb Deatrick, and I am joined today by my longtime colleague, Andy Coburn. We are the principal architects of this project and the authors of the report that we're going to discuss today. We do want to just shout out to the Rural Health Action Network, under whose auspices this project was undertaken, the New England Rural Health Association, which was the organization that was our administrator for the project, and finally the Maine Health Access Foundation, the funder of this initiative. So we thank them all. Particularly, we want to thank Charles Dwyer, Senior Program Officer for MEHAF, as well as the 17 interviewees that we met with in Maine and elsewhere, and some rural colleagues in Vermont, Oregon, and Idaho. We thank them all for their assistance. So neither Andy or I have anything to disclose with regard to commercial relationships for this project. So before we start, just a few points, 4 points about why we undertook this project and what you're going to hear about today. We are going to be focusing on an area called health-related social needs. We did this because, frankly, there is a lot of activity, both in the research and the practice arena, on trying to address in a more effective way health-related social needs of patients in the healthcare system. You're also going to hear some background about what's going on with regard to this whole area of inquiry, both in Maine and across the United States, to align healthcare, public health, and social services in particular to address these needs. We're going to specifically zero in on the project focal areas that we chose: partnerships and governance, and financing and payment. There are other factors that affect how health-related social needs are addressed, but we wanted to focus on these. We did focus on these because of the prominent role that each of these plays in overall initiatives. And then finally, and most importantly, we're going to talk about a demonstration that would test how community-based alignment strategies might be tested or assessed here in Maine. Next slide, please. So we have some discussion questions, and we want you to be thinking about keeping these in mind as you listen to some of the background and other points we're going to be making. We specifically want your reactions to a demonstration initiative that we are proposing and some aspects of that, partnerships, governance, financing, and other. Be thinking about whether you know of potential communities in regions in Maine that you think might be ideal for a demonstration project. What kinds of challenges and opportunities you might foresee as this demonstration is undertaken. And then importantly, what is it going to take to move this concept forward in terms of next steps? So be thinking about those questions. We'll come back to those at the end of our brief presentation. And next slide, please. Yeah, I'm going to just an introduction. So Andy and I are going to tag team slides a little bit from here on out, so you'll hear from both of us. So turn it over to Andy.
Okay, thanks, Deb. To delve a little bit deeper into the question of why this project, the Rural Health Action Network is a group of people who have voluntarily assembled to provide their expertise in developing a strategy for improving health in rural communities. And we've been, and I'm part of the group, and we've been a part of this group, we've been party to this project for many years. And this grew out of discussions of the Rural Health Action Network, but it also grew out of an event that occurred in which the Centers for Medicare and Medicaid Services put out an RFP for a national demonstration, the so-called CHART demonstration, to engage in rural health system transformation. And this was explored in Maine extensively, both by DHHS and by individual hospitals. And in the end, it was decided, for a variety of reasons, which we don't need to get into, not to pursue this. And so the question that Deb and I asked, and the Rural Health Action Network asked, is why couldn't we do a demonstration in Maine that actually fit the context of Maine? Because that was the primary concern about CHART, is that it just didn't fit, both in terms of the financing strategies, and other features of the demonstration just weren't particularly accommodating to our context. So we pursued this project knowing that there's a lot of evidence now that unaddressed social needs really affect healthcare access, costs, outcomes, and especially among vulnerable populations. And that there are current efforts underway to identify the social needs of individual patients, but not all of those are coordinated, and we really don't know what their effects are, and it's pretty haphazard as to who's pursuing what. And so we felt that there was a real need to look more population-wide at strategies that could change systems, and not just the individual practices of a primary care physician's office or a hospital or other healthcare provider organization. And in the end, we really felt that there was a need for better systems of care, which is easy to say, but very difficult to achieve. And so this project was really designed to generate what we know about this problem of linking public health, social services, and healthcare more effectively at the community level and at the care delivery level. We hoped that that could translate into a demonstration.
So Andy, just a quick point. Sorry to interrupt, but just a quick point or comment about my 20 plus years working in the healthcare system for the state's largest system, Maine Health, and having met with many, many primary care physicians and other clinicians over the years who really are struggling and really do want to do a better job meeting the social needs of their patients. Many systems, including Maine Health, are investing in different platforms, different screening tools, different training programs, et cetera. And they're making a very honest effort. But as Andy mentioned, it really is not coordinated at the community level. And there's one of the most serious deficiencies that we found, and we'll be talking about a little bit later. But it is to say that the healthcare system in Maine and elsewhere is making progress, particularly in terms of instituting screening tools and screening processes. The question now is how to integrate those into a true system.
To go beyond screening to actually address the needs that patients present. So you might be asking the question of, so how does this differ? How do health-related social needs differ from the social determinants? And we're not going to spend a lot of time on this, but the social determinants really are what we refer to as the context of communities, of regions, of states, where the economic and social forces come to play, environmental forces come to play on the health of the population. Health-related social needs are maybe a subset of that larger context in which we're talking about the social needs as they present themselves in the healthcare system or in the social service system as problems that need to be addressed by changing the way in which we deliver services, either the social service side, public health side, or the healthcare side. And whole person care is just a new term that's being used to kind of put those pieces together, where the healthcare system, can be aiming for integrating both social care and the healthcare services. And it's focusing on kind of delivery system reform.
Just a quick comment about that.
Yeah.
A quick comment about that. In former times, we used to refer to the whole person care as patient-centered care. I think now recognizing that patients are both living in the healthcare system and outside the healthcare system primarily. So it's a much more accurate term in terms of reflecting the care that people need for their entire lives and livelihood and well-being.
So we were encouraged to undertake this project by the fact that there is a lot going on. There's a lot of focus on this problem of alignment between different sectors. There are new payment models that are coming, that are being used and being thought about for population-based care. And we have a lot of building blocks here in Maine that are really important in terms of what's going on in the community. We have the Maine Shared Community Health Needs Assessment. We have expanded use of community health workers and community paramedicine and care teams around the state. And then we have the pandemic-related funding, which gives us an opportunity to really think about how that funding could be used. I won't spend much time here. If you were interested in how we did this, we basically did the usual look at the literature and interview a lot of people, including people, as Deb mentioned, in other parts of the country that have been doing this work. We talked to community-based organizations here in Maine, all the accountable care organizations in the state, and we had extensive conversations with Maine Care, with senior leaders in the Maine Care program. And we had a lot of vetting of what we came up with by a variety of individuals and the Rural Health Action Network and the funders and so forth. So the National Academies of Science, in their report on integrating social care into the healthcare system, put out these 5 steps. And it's awareness, sort of identifying, how do we identify social risks, adjusting the clinical process, changing the workflow in healthcare to take into account the social needs. But the focus of our work was really on assistance, alignment, and advocacy. And those are the elements that have to do with actually connecting patients to resources, partnering with community and social service and other providers to create a more seamless integrated delivery of services, and advocacy for better systems of care and the realignment of resources that are needed to support that integrated delivery of care. This is a graphic from the Georgia Health Policy Center that is leading the Aligning Systems for Health initiative, which is a Robert Wood Johnson Foundation funded initiative. And it puts together essentially the core elements of what is needed to really align systems. And I just want to focus on 2 things here. This is it's not that complicated a slide, but the whole shared purpose and governance piece of this picture is essentially what we were focused on, because those are 2 critical elements related to the partnerships that need to be developed between healthcare, social services, and public health organizations at the community level. And financing becomes a really important element to supporting people coming to the table and supporting the integrated care that ultimately we'd like to see happen. It's easy to put this slide together. It's much harder to actually make it happen because, as all of us know who participated in community partnerships, the power dynamics, the issues of equity, the issues of building trust between social services and healthcare and public health are very significant and can't be overlooked. But the questions that we're going to pursue now with this framework in mind really have to do with partnerships and governance and the financing strategies. And we'll just say a few things very quickly about the core elements of those strategies. Deb?
So thanks, Andy. So I'm going to make some brief comments. Next slide, please, about the partnership and governance strategy component that we did a deep dive into. And this was both from the literature and from the interviews we did with folks in Maine and folks in other rural areas of the country. So it was, these points are derived from both published reports as well as the on the ground, boots on the ground experience of many. And again, as Andy mentioned, these things seem kind of simple and self-evident, but these issues regarding partnership and governance have oftentimes been the make it or break it in terms of a successful initiative. Issues around a shared and inclusive vision, meaning that there needs to be transparency of folks who come to the table. The healthcare system and community-based organization systems have existed in many places and cases in silos. There's separate language, there's separate rules of engagement, there's certainly separate financing issues, et cetera. And there has to be a coming together of these partners and in a very transparent way, and recognizing that the power differential needs to be flattened for these initiatives to work. Incentives, we heard much about this from folks here in Maine and other places. The value that is derived by coming together to work on an initiative, whether it's about food, whether it's about housing, whether it's about transportation or all of the above or other issues. You know, the basic belief systems and value systems, as well as what value is going to be derived, financial or otherwise, from the partners. The incentives, and not just getting people to the table initially, but keeping them there. And then finally, effective governance, structure, and accountability. Again, there needs to be transparency, equity, and decision-making, accountability, those who make decisions being held accountable to both help people understand how those decisions are made, how resources are allocated, et cetera. And again, these are hallmarks, these three areas are hallmarks of effective initiatives, both here in Maine and elsewhere.
And I just want to add, I don't think there are any existing structures that give us the kind of governance framework that we ultimately would need in order for this to be successful. And I think we're talking about how we build a governance structure that is inclusive in the way that Deb was talking about. I'll just say a few things about financing and payment strategies because—
Yeah, Andy, just before you go on, I had meant to mention just one issue about the use of collective impact as a model, both here in Maine and elsewhere. Obviously, there have been a lot of permutations of the collective impact model over the course of the last decade, but interestingly, all of the successful initiatives that we interviewed are using some version of collective impact, a neutral or central organization that is vested with the responsibility of not just governance and structure and accountability, but also bringing people to the table, providing those incentives, et cetera. So whether or not that is, again, we'll be talking about the demonstration in a minute, but it was interesting to us that that particular model was quite widespread in terms of its adoption.
So there are a lot of thorny details with respect to how one puts together a financing and payment model that would do a better job of promoting integration across the three sectors. And I'm not going to be able to say very much about the specifics that are in our report. I'll keep things pretty general because we're short of time. But the first part is, what is healthcare? And historically, we haven't paid for a lot of services that we define as social care as healthcare systems, as healthcare. Health plans don't pay for a lot of things that would be social care. The exception, of course, is the Medicaid program, which has provided services for a variety of vulnerable populations to enable people to stay in their own homes in the case of older people or people with disabilities and so forth. So we do have some models, but not a lot. There are increasingly mechanisms for identifying social needs using the ICD-10 codes, which we talk about in the report. Payment models, we're all into value-based payment, and whether or not value-based payment and accountable care organizations really can achieve enough savings to really fund the kind of social care and integration that we're talking about is dubious. So we're really having to think, I think, more about new capitation-based models, which we talk about in the report. And finally, at the community level, there are interesting things going on with the use of community benefit. We have the shared community health and needs assessment in Maine, which can be built upon, but we think there are promising opportunities there at the community level to increase the amount of financial capacity for integration that is going to be needed. And finally, payment accountability and measurement. The whole return on investment problem that we face in public health, where all of our investments are long-term investments, but everybody wants to measure short-term gain in terms of 1 year or 2 years, and that's very difficult. And so we need a new mechanism. So in probably the 5 minutes that we have left, we just want to provide a quick overview of the demonstration, which Deb is going to walk us through.
So thanks, Andy. So we are proposing in the report to undertake a major demonstration initiative here in Maine. It would have a health-oriented approach. I'm not going to read all of these, but an important concept here is the co-creation of specific strategies among local partners. So what that means is that once an area, a community, a region is identified, that region and the partners in that region would actually develop the details of the demonstration initiative. We think it's vitally important that it be reflective of that local area and the individuals and organizations that are active there. Obviously, we've talked about equity and decision-making. There will need to be upfront commitments from a variety of different payers and players and other investors. We do want to align with some of the interesting and important initiatives that Maine Care has underway, as well as for blending funding opportunities. And then finally, we are looking upon this demonstration as essentially a learning initiative. And so as it progresses, information that's derived along the way will be plowed back into the implementation strategy and hopefully improve that. We're contemplating a budget of around $5 million over a 5-year time period. There would be a planning period of 18 months. And then a course of implementation and evaluation over the ensuing 42 months. We're thinking about a demonstration advisory committee to be determined in terms of who would sit on that, as well as what we're calling a technical assistance hub, recognizing that many of the initiatives that we talk to here in Maine and elsewhere have needed a lot of technical assistance with regard to financing strategies, training around governance, engagement processes, leadership training, et cetera. And we think that there could be potentially a variety of different organizations involved in the TA hub. We also contemplate an RFP process to identify the demonstration sites, and that RFP would contain hopefully many of the criteria that we've talked about today and are reflected in our report. And then finally, there would be obviously the funding and oversight features. And this next slide just puts all of these pieces into a timeline, phase 1 through phase 5. So we have a lot more information about the proposed demonstration in the report. And we're hoping that many of you will want to read the report and give us feedback. But back to the discussion questions that we posed in the beginning, we'd just like to hear reactions to what people think about the components that we've outlined, partnerships, governance, financing, anything else. and whether or not you know or see potential communities and regions in Maine are right for such a demonstration. What challenges and opportunities do you contemplate? And then what do you think it's going to take to move this forward? The obvious piece there is funding. And we know there are many other our potential challenges and opportunities there too. So we'd just like to open it up. And Becca, I think we'll turn it back to you as the moderator for the Q&A.
Great. Thank you so much, Deb and Andy. That was a very thought-provoking presentation. And we have some questions that have come in, and then I would encourage people to use the chat feature in the platform to offer your insight into these discussion questions, and to keep using the Q&A feature to add your questions. We do have a couple minutes to take them. And a lot have come in even since I just looked at this. So, okay, first question, big with a lot of punctuation marks. Where can we find the report?
So,
next slide, please. Thank you.
So we haven't started distributing the report, even though it's completed. And so if folks could contact me or Deb, we will put you on the list to make sure that we email you a copy of the report or the link to the report. The report's going to be on the Rural Health Action Network website, which is part of the New England Rural Health Association.
Great, thank you. Let's see here. Could the demonstration be applied to a smaller community, like a project for affordable housing, which is being designed as a hub for access to healthcare and social services?
I mean, housing is for sure one of the social needs that communities may identify as the most important thing for them to be doing, and they may have a collaboration, a partnership around that. So for sure, that would be the kind of intervention that we would be looking for as a partnership between the healthcare system, social services, and public health. I would say that there's a real need for cooperation, not just within a community, but also across communities. And so I personally would advocate for a larger, I don't want to say region as in multi-county, but a larger regional approach to addressing some of the problem, because the resources in very small communities sometimes just are too limited to be able to do what needs to be done.
Yeah, I think the only thing I would add to that, or only point, is that as we thought about the demonstration, we do believe that the population will need to be defined, the population of patients, and that population will need to be, there will need to be some assessment as to what the leading health-related social needs are among that population. Again, it might be multiple issues. It could be one issue such as housing, but again, it's one of the reasons that we feel that a lot of work will need to be done once the region or community is defined to really nail down what those specifics are in order to be able to assess the impact of this initiative, of the demonstration.
Thank you both. We're at time, but there are a lot of questions still in here. So I would just encourage folks to take advantage of Deb and Andy's emails and reach out to them with your questions. There is a flag. I guess this is more of a comment than a question, so I'll offer this feedback, which is to please include FQHCs in your analysis. There are 20 centers, 80 locations embedded in local communities, and they are steeped in including social determinants in care, and many are currently very engaged and innovating in these areas. So that's just a comment. So with that, I want to thank Deb and Andy again for being here, for being our final session at the end of day one of our conference. I want to thank all of you for joining us today and for participating in this session. Please do not forget to complete the session evaluation under the feedback form. And we will see you back here tomorrow morning at 8:30 a.m. for the start of day 2. We'll be kicking it off with the plenary panel, Creating Connections Through Disruption, how public health and economic development are intertwined. So thanks again to all of our presenters and our attendees, and we hope you have a wonderful evening.